Distal radius fractures, today's topic, very important topic for you people because it might come in short note and it can come as a short case also, because for your exam right now there is no long case in orthopedics, but you will definitely have some short cases. And it's very important to know as well, because any exam you are going to appear after your final MB, from orthopedics this is a very important topic. So you should know certain important things about that, and we are going to cover three important fractures in distal radius today. One is a Colles fracture, another is its synonym Smith fracture, and Barton's fracture. So let's start with Colles. So Colles fracture was described first by Abraham Colles in 1814. It's the most common of all fractures in elderly population. You have to know that whenever there is a fall on an outstretched hand, so there are certain fractures that happens throughout the epidemiology of the person. When a fall is on outstretched hand in a child, then the most common fracture that you have is a supracondylar fracture. Fracture is in the elbow. Now, from the child, if it goes into adult, then the fracture that happens most common is a scaphoid fracture. Now, as it goes into an elderly person, the fracture comes into the distal radius. Why? Because that is a metaphyseal zone, epiphyseal metaphyseal junction, where the bone is weak in the elderly because of osteoporosis. So Colles fracture is a very common fracture in any elderly person. Just whenever you see, you might have seen your grandmother or grandfather at home just sustain a fall and have a swelling around the wrist. So that is what is Colles. Okay, that is a very, very common fracture in elderly, and it happens fall on an outstretched hand. Okay. So this is a transverse fracture of the distal end of the radius at the cortico-cancellous junction. That's what I was mentioning. And it is typically at that region because there is a very weak force acting on the bone at that point. The strength of the bone decreases at that point, and that's what happens in an elderly person because of osteoporosis. And that's where the fracture happens. So there are certain components of the Colles fracture. So you have to know. So whenever there is a fracture, we describe the fracture in certain terms. The most important term is displacement, whether it is a displaced fracture or whether it is an undisplaced fracture. Next is angulation. You have to know how it is angulated. Okay, at a paper now? A4 paper. So you have to know how it is angulated. And the next important word that is there is called translation. So translation, whether it is translated or not. Okay. Suppose this is your radius. Okay. Now here is your wrist joint. Here is your elbow joint. So it is the distal radius fracture. So the fracture happens, suppose, at this area. Now you have to know what is the dorsal and what is the volar part of your forearm. So that is an important thing to know if you want to understand Colles. So whenever you stand in an anatomical position that you have learned in anatomy, so this is your volar aspect, this is your dorsal aspect. So there is a dorsal displacement. So suppose if this is your volar, this is your dorsal, so displacement will be like this. So it will be angulated like this. So these are two different terms, displacement and angulation. But what I want to say is, whenever there is a fracture, if this is a volar, this is a dorsal, the fracture will be angulated like this, and it might be displaced. Now if after fracture it goes like this, this is displacement. But if it is not displaced, just going this side, this is angulation. And if it is both happening, then it is displacement and angulation. And what is translation? Translation is medial lateral. So if there is a very high energy force, if there is a low energy force, it might just be like this. If it is a little bit more, it can be angulated as well as displaced. And if it is very high, then it can be translated also. So this is a full component of a Colles. So if you see a Colles fracture, there are certain components. There are dorsal displacement, there is a dorsal tilt. Tilt and angulation is the same thing. And there is a translation also. So there is a radial translation. So it goes towards the radius, not towards the ulna, radial translation. And there might be an associated ulnar head fracture also. So these are certain components of the Colles fracture. Let's see if it is mentioned in the slide. So typical dorsal displacement, that is the most important thing. So that will be displaced. Now whether it is translated or not, whether it is completely displaced or not, that depends upon the energy of how the fracture is happening. Okay. let's see whether the components are mentioned. The distal end of the radius articulates with the carpal bones. Normally, the articular surface of the radius faces ventrally and medially. The radius surface is like this, volar. Ventral means volar, dorsal is this side. So if you see a distal radius, I think we have an X-ray, let's see. Somewhere. Okay, let's see where do you have an X-ray, I will let you know. So what happens is that if you see our hand, you see we can move almost like this. But if you see dorsum, it is not up to 90 degrees. It is less, almost 80 degrees. But if you go ventrally or volarly, there is almost 90 degrees. Why? Because our distal radius articular surface is like this. It is faced volarly. So there is an angulation. So there is almost 11 degrees of tilt, volar tilt. So that allows us to do jobs like this, eating, washing, whatever you want to do, curling. So this is the thing that helps your hand or the wrist to flex. But dorsally, you cannot do that much. See, dorsally, even if you try, it will come to this angle. If this is plane, parallel, it will come to this. But if you do volarly, it is almost 90 degrees. So distal radius is angulated. So there is a volar angulation to it. In the Colles fracture, that is lost. And there is a classical deformity that can come as a word in your exam, and that is called a dinner fork deformity. Have you seen a dinner fork? It comes like this and goes up like this. So that is how a dinner fork deformity looks, and that is a typical presentation of how a Colles will come to you in your OPD. So we have a lot of patients coming in the outdoor with Colles fracture, and if you guys are coming for clinics, and you might have seen also. So that deformity is very classical. You can see the deformity and you can make out without doing an X-ray, yeah, this looks like a Colles. But how much component of Colles are there, how many components of Colles, that only X-ray will reveal, okay? So, mechanism of action, history of fall on an outstretched hand, force is applied in length of the forearm, fracture occurs transversely at the corticocancellous junction. Very important component of Colles is it has to be an extra-articular fracture. It cannot be an intra-articular fracture. If it is an intra-articular fracture, then the total term of Colles changes. It becomes a different fracture. It is not Colles anymore. So if you see, you understand what is extra-articular, intra-articular, right? Extra-articular means the fracture will be away from the joint. There will be no fracture line going inside the joint. If it is going inside the joint, it becomes a Barton's fracture. Intra-articular fracture is a Barton's fracture. Extra-articular fracture can be Colles or Smith. It depends upon the displacement. Colles is, if it is a dorsal displacement, it becomes Colles. If it is a volar displacement, it becomes Smith. Now, how to tell the displacement? That is important thing. Displacement in any fracture is always related to the distal fragment. You should never see the proximal fragment. You cannot see how this part is there. You have to always see how this part, distal part is there. Displacement is termed for the movement of the distal fragment, not for the proximal fragment, okay? So yeah, so component are already there, see? Dorsal displacement, dorsal tilt, radial displacement, radial tilt, supination and impaction of fragments. So this is the entire spectrum of Colles fracture. So if a Colles fracture comes in your exam and you have to write the components of Colles, this is one important slide you have to memorize. How it happens, that is what I was explaining. So if this is your distal radius and this is your volar and this is your dorsal side, so see from the lateral X-ray you will be able to see. In the lateral X-ray you will be able to appreciate the displacement. And if you want to see the translation, you have to see the AP view, okay? So if you see the lateral view, so this is the dorsal displacement, dorsal tilt, dorsal displacement. Now if you come to the AP view, we have to see radial translation. Here is the ulna, here is the radius. So radial translation like this, okay? Impaction of fragments, what do you understand by impaction? If it is coming like this, it is an impaction. Classically, there is a loss of height. Loss of height means if you see a distal radius anatomy, আরেকটা পেপার দাও A4 আছে তোদের একটা যে কোনো একটা ইয়ে দে because unless you understand this, you cannot memorize Colles fracture. It is very clear. Orthopedics is pure mechanics. If you understand the mechanics, then you don't have to memorize. You will remember it forever. So I will show you too, don't worry. So look over here. So this is your AP view. So when you see the radius like this, okay. So this is your distal radius, and this is your ulna. This is the head of the ulna, and this is the foveal process. So there is a normal X-ray will have certain important relations. What? This is the radial styloid. See, it is more than the ulnar styloid. Can you see? It is height is there, and that is why what you can do. You see, you can move only up to this in your hand. But see in the ulnar wards how much you can move. Why? Because in the ulnar side you have a lot of space for your wrist to move. But the radial styloid will not allow your hand to move this side, because your radial styloid is hinging on that. Okay. In a normal anatomy of your wrist, this radial styloid should be height over the ulnar foveal process or the ulnar styloid process. But in a distal radius fracture, Colles fracture, what happens? So this is the fracture that I have mentioned. See this is the fracture line, and this is the articular surface. The fracture is away from the articular surface. So this is an extra-articular fracture, first point of Colles. Second is, now if you see this diagram, this is the lateral part. I will show you what I mean by the lateral thing. Now this is the articular cup. Okay. Now can you see it is angulated like this? This is the volar side, this is the dorsal side. How much is the angle? This angle is almost 11 degrees. Okay. So that's why we are able to do like this more and not like this. Because if you want to move dorsally, there is a dorsal hinge that will prevent to do it. But in Colles what happens? The fracture will be happening like this, and this fragment will be tilted like this. So what happens? Your volar movement will become restricted. And what will be the difficulty of the patient? Eating, washing, gripping anything. So these are the classical deformities. If you understand this figure, you can understand every distal radius fracture. But you have to first understand the anatomy of a normal distal radius. Normal distal radius, in a lateral view, there is a tilt, 11 degrees of tilt. If you see like this, the height is more in the AP view, and there is also a tilt. See this angle. This is not a tilt, this is an angulation. So this is called the radial angulation. So this is 22 degrees. This is again 22 degrees. This is 11 degrees. And if you see this height, this is 11 mm more. So this is called the rule of 11s. So if you remember the rule of 11s, you will always remember 11 degrees volar tilt, 22 degrees angulation of the radius, and 11 mm height. So the rule of 11s in the distal radius. But in Colles, all of this is disrupted. How? I will again let you know. So let's come back. So take a snap of this slide because this is very important. All the components of the Colles is given over here. So we have the dorsal displacement, dorsal tilt, radial displacement, radial tilt, supination, impaction. Of supination is nothing but a rotation. Okay. There is a rotation, but there is not always the component which is always seen. It is sometimes seen, it's not always. But if they ask you in exam, you have to tell all this, because this thing you always have to remember for a Colles. Akhon obdi shob clear? Kichu doubt? Okay. So now let's come to the associated injuries. Now Colles associated, see, Colles is a fracture of distal radius. Okay. But if the force is too much, then it can cause certain other fractures also, because you have to understand this is the joint. Distal radio-ulnar joint. Wrist joint is nothing but a distal radio-ulnar joint where the radius has certain ligaments, certain fibrocartilaginous complexes that goes and attaches with the ulna. Okay. One important component is the TFCC, triangular fibrocartilaginous complex, that goes around the distal radius, wraps the ulnar head and the styloid. But in a Colles, what you will always, almost always you get is an ulnar styloid fracture, and that is the first thing that has been written. See, fracture of the process of the ulna, because there are certain components of the TFCC, there are certain ligaments of the TFCC. You see, TFCC is a complex, so there are 6-7 ligaments. You, at your level, you guys don't need to know. Okay, but there are certain ligaments that are going to pull it, and that's why you get a fracture of the ulnar styloid also. Okay, Rupture of the ulnar collateral ligament. This ulnar collateral ligament is also a component of the TFCC, okay? Rupture of the triangular fibrocartilaginous complex of the ulna, rupture of the interosseous radioulnar ligament causing radioulnar subluxation. That is a very, very rare thing to happen if there is a very high velocity injury. If the fracture has made the ulna come out, pop out, then only you are going to get that. But in a usual Colles, you are not going to get that, okay? But you have to remember, these are the associated injuries, of which the most common and the most important is the fracture of the ulnar styloid. So clinical features, patient has come to you, fall from a, suppose say, fall from the bed while getting up. Elderly woman has come to you, 60, 65, 70 years, I have fallen from the bed while getting up, okay? How is the patient going to come and present to you? First complaint that she is going to say is pain, tenderness, swelling, and that is the first thing they are going to say. And that bend is because you get a displacement. You get a tilt in the distal radius fracture. Classical deformity is a dinner fork deformity that I was telling. For a Colles, you get a dinner fork deformity, and the synonym of Colles, that is the Smith, you get a garden spade deformity. You have seen a garden spade, it is like this. They use, so it is opposite, and in a dinner fork, that a fork you are using, you are going to get like this. Very simple. If you understand Colles, you will understand Smith. Only difference is Colles there is dorsal displacement, in Smith there is volar displacement. That's all. There is nothing else to remember. And see what is written, radial styloid comes at the level of the ulnar styloid. That I was mentioning over here. That is what you mean by impaction of fragments. So this is the normal anatomy, but when there is a fracture, it comes down. And when it comes down, the radial styloid will come in line with the ulnar styloid. So that is what is the component impaction of fragments, and that is what they have mentioned here, clinical feature. This is the dinner fork deformity, see. This is how you are going to get a Colles fracture, okay. So radiological finding, see everything I have mentioned in the paper. AP view, you are going to see the lateral tilt and displacement. In the lateral view, you are going to see the dorsal tilt and displacement, okay. You have to see the fracture at the distal end of the radius or the corticocancellous junction, and it can be associated with an ulnar styloid process. Clear? Okay. So see, this is the X-ray I was going to tell. See. Now this is the AP view, this is the lateral view. Okay. In the AP view, see this is, can you appreciate the impaction? There is a fracture, but see it has come. The radial styloid is still at a higher level than the ulnar styloid, but there is still a loss. Can you appreciate the fracture in the ulnar styloid? The ulnar styloid, there is a fracture, see. So this is the fracture in the ulnar styloid. This is the fracture line. This is an extra-articular fracture. See, there is no fracture line inside the joint. Whatever is there is outside the joint. So what you are able to see, there is not much translation. There is not much translation, but see the lateral view. This is the shaft of the radius, and can you see the displacement? Now, how do you understand this is the volar and dorsal side? How will you understand this? Always look for the thumb. The thumb in the lateral view will be always towards the volar side. This is your first metacarpal, see? This is your first metacarpal. So if this is volar, so this is volar. And this is dorsal. Another way how to understand which is volar, which is dorsal. Volar is thick. All your muscles, all your important arteries, your median nerve, your radial artery, ulnar artery is all over the volar aspect. So it takes much more soft tissue shadow. But if you go on the dorsal, you will only have the extensor tendons. There is nothing. So if you see this is the soft tissue shadow. Can you appreciate shadow? See how much soft tissue shadow is here, and see how. So this is the dorsum, this is the volar. So this is the two simple tricks to understand which is the volar and which is the dorsal side, because unless you get that, you cannot say this is Colles or Smith. So this is the dorsal, and see it is displaced like this. Can you see appreciate the displacement? So that is the dorsal displacement. Now identify the carpal bones. What is this bone? Very good. What is this? Lunate. Lateral view, what is this bone? How can be scaphoid? What is the meaning of lunate? Looks like a lunar shape. So what is this bone? This is lunate. Scaphoid is this bone. It will be behind the lunate and it will be overlapping. But what you see in the lateral view, shaped like a half moon, that is lunate. The name is going to say it all. You don't have to remember by heart. Orthopedics is again mechanics. You just have to understand it. Okay, so this is clear. Mechanism, X-ray, how a Colles fracture looks, what are the components of Colles, how you are going to appreciate which is the dorsal and the volar side. And if you look very closely to the X-ray, appreciate the soft tissue shadow, you can find the dinner fork deformity over there. Okay. So this is for a young child. I'm not going to this. Now, important thing is how to go about the treatment. Undisplaced fracture, Colles, give it a cast. Colles cast, you have to give a Colles cast. For displaced fracture, sometimes if you are very experienced, you can do it in your outdoor. But if you want to do a proper reduction, you need to take the patient to the operating theater and then do a closed reduction under C-arm guidance. Okay, you have to do it under image intensifier. So that will help you correct the height. See, the important things that you have to correct in a Colles fracture, you have to gain back the radial styloid height. Next, you have to restore the volar tilt. It cannot stay like a dorsal tilt. Next, if there is any translation, you have to get it back. Next, you have to get back the normal height of the radius. So these are the things that you have to correct. How you correct is totally up to you. If you are confident, if you are experienced enough, you can do it in your outdoor setup. But if you are not sure whether it is corrected, whether it is going to stay like that, then you have to take the patient to the operation theater. Now sometimes what you will see, there is a lot of impaction and there is a lot of comminution. I mean a multifragmentary fracture, then you have to give certain wires to hold it in position, and those wires are called the K wires, Kirchner's wire. So that is going to hold your reduction, because if you are not going to give that, elderly patients, osteoporotic bone, the bone is going to collapse inside the cast also. And then again after 4 weeks when you open the cast, you are going to get a deformity. So at your level, just remember undisplaced fracture, give it a cast, conservative management. If it is a displaced fracture or a multifragmentary fracture, it can be a closed reduction, manipulation, casting, or a closed reduction and a K wiring. Okay. Sometimes we do an ORIF, I mean open reduction and internal fixation, and then put a plate also. But for that is for very high demand patients who are a little bit on the younger side, suppose 45, 50, who is walking, you want to give him back the full mobility in a very short time, then you can do plating. Okay. And that is what is written over here. So that is the entire thing what I have told you. So this is the closed reduction manipulation. A person is there who gives traction. Another person gives counter traction. Orthopedics is all about traction and counter traction. How you give, that is totally up to you. And you have to give it. Unless you give it, you are not going to correct the deformity. And then the distal fragment which is like this, you have to move it in volar position. You have to get back the radial styloid height, so you have to remove the wrist like this. So classically, so how you, so how you are going to do manipulation is like, another person is going to hold like this. Your one hand is going to hand over the thumb and your 3 fingers over this 3 fingers, okay? So you are going to give a ulnar deviation. Pull your thumb so that all the ligaments that are attached to the radial styloid is going to get back the radial styloid, and you do like this so that the radial styloid gets back the height. Next important is you give a volar translation so that the dorsal tilt is corrected. So this is how your hand should be when you correct. Another person holds from the elbow and gives a counter traction, and the person who is going to apply the cast is going to give the corrections and then allow another assistant to hold, and then you are going to wrap a soft roll and then you are going to put a cast. That's all. Okay. Colles cast, see what I told, palmar flexion, this is the palmar flexion, and ulnar deviation. These 2 important things you have to understand. How it is done, I have shown you practically. Okay. This is how a K-wire fixation is done. Not needed at your level, just for academics. I'm telling you, this is how it is done. You can do external fixator also. That is up to you, but it doesn't work that much because you are not going to correct the angulation. See, the main part that is untouched. They have spanned up and below the joint. And this is how you can fix it like a plate inside. Complications, very important part. Early complications are the carpal tunnel syndrome, median nerve injury, you have the reflex sympathetic dystrophy, you can have TFCC injury, and you can have subluxation. Late, very, very common is you have a deformed wrist. So that is called a malunion. Unlikely it goes into non-union, it is not much of a non-union. And you have stiffness and extensor pollicis longus, EPL rupture. You have a tendon over here that can get ruptured. Okay. This is for academic purpose, not much of understanding here. Smith is just reverse of Colles. Whatever you have learned in Colles is just opposite. The most important opposite thing, if there is a dorsal in Colles, here it is a volar. Okay. What you get the deformity? Garden spade deformity. In Colles you have a Dinofolk deformity. In Smith there is a garden spade deformity. Treatment is again same. Whatever, so Colles is the most important fracture that you should understand. Smith is just the opposite. Treatment, everything is same, only the deformity is opposite, that's all. See how a Smith fracture, see, you can understand the volar, see how volarly it is angulated. In Colles it was opposite, but in Smith, see how it is angulated. So Barton's fracture. Barton's fracture is an intra-articular fracture of the distal radius. So the fracture is going inside the intra-articular thing. Okay? Why the chapter slide? Treatment again is close reduction and plaster cast and internal fixation by plate and K-wire.